due to some reasons, we have preponed that care topic to this week. Thanks to Rani Madam and Shankar for accepting a very short time without postponing the today's class.
మధ్యలో శ్రీనివాస్ లేడా సార్? మధ్యలో శ్రీనివాస్ లేడా?
శ్రీనివాస్
మధ్యలో శ్రీనివాస్ లేడా? ఇద్దరు పేర్లు చెప్పారా?
ఓ సారీ, రెండు మేడం ఫోన్ చేశాను. శ్రీనివాస్, థ్యాంక్స్ శ్రీనివాస్ ఫర్ immediately accepting this topic.
Thank you, sir. Thank you.
Okay. So now I request Dr. Shankar to start the presentation.
Shankar, start.
Shankar, ఏమైంది?
హలో,
ఏమైంది శంకర్కి?
సిగ్నల్ పోయినట్టు.
Presentation. Yeah, this is the presentation. Yes, PPT. This is red color. Hello.
Srinivas, start presentation. Yeah.
Okay, sir. Respected teachers and all my seniors, today I'm going to discuss some points on OP poisoning. Coming to introduction, organophosphorus compounds are a diverse group of chemicals used in both industrial and domestic settings. So they can be their injections should be either either accidental or incidental. Their mortality rates depends on the type of compounds used and amount of amount ingested, general condition of the patient, delay in discovery and transport, insufficient respiratory management, delay in intubation, and weaning from the ventilator. Before going into OP poisoning, I just want to add some points on general poisoning management. The basic approach to poisoning patient mainly includes these 6 steps. Initially, it is stabilization, which includes we should take care of airway, breathing, and circulation, and thereby initiate by confirmation of intoxication. These airway should be secured even on moderate to severe poisoning, and hypotension will be sorted with fluid resuscitations. And we have to send laboratory investigations which are required. Coming to cleaning, mainly includes gastrointestinal system and skin and eye. For gastrointestinal systems, we generally use gastric emptying or gastric lavage. Activated charcoal can be used. For skin decontamination, non-absorbable soap and water should be used, and clothes should be removed and disposed of with caution. For ocular or eye decontamination, irrigation of eyes with normal saline should be used. We have to use proper antidote, which is required for the poison. And coming to toxin elimination and augmentation, forced diuresis or urinary pH manipulation should be used. Multiple dose activated charcoals can be used, and extracorporeal removal of toxins, which includes hemodialysis, hemoperfusion, and hemofiltration, can also be used. Toxin eliminations can be used. Yeah. And later on, patient should be observed. Close observation should be required, and later shifts to ICU for close observation and monitoring. Coming back to OP poisoning, these are mostly seen on these types, which includes insecticides, nerve gases, herbicides, and anti-helminthic agents. These are the insecticides which we can see generally, and these are the nerve gases of which sarin, soman, and tabun and VX, which are used for bioterrorism, etc. Main mechanism of action for OP poisoning mainly includes of these inhibits acetylcholinesterase in synapse and on red blood cell membrane, thereby causes excess of acetylcholine at receptors in synapse, which leads to increased muscarinic and nicotinic effects. This diagram shows here it shows acetylcholine signaling at the synapse. This is a presynaptic neuron and postsynaptic neurons. These acetylcholines will come and transfer by binding with the ACE receptors, acetylcholine receptors, and comes to here. Acetylcholine esterase stops the acetylcholine when the activity rises, like an acetylcholine requirement. Acetylcholine can be neutralized with ACH esterases. When the individual consumes OP poison, these acetylcholine esterase can be stopped with esterases can be stopped, thereby excessive can be seen. These are the effects mostly seen on these conditions are muscarinic, nicotinic, and CNS effects. Coming to muscarinic, these features are due to overstimulation of muscarinic ACE receptors in the parasympathetic systems. This can be easily remembered with mnemonic dumbbells, defecation, urination, meiosis, bronchoria, bradycardia, bronchospasm, emesis, lacrimation, and here it is salivation. Coming to nicotinic effects, factors due to overstimulation of nicotinic ACE receptors in synaptic system, which includes hypertension, tachycardia, mydriasis, sweating, muscle weakness, fasciculations, and paralysis. Coming to CNS effects of OP poisoning, these are due to overstimulation of muscarinic and nicotinic ACE receptors in CNS. These causes confusion, delirium, seizures, respiratory failure, coma, dystonia, and caudal rigidity can be seen. For diagnosis of poisoning, mainly you can see in low acetylcholine esterase levels in RBC, and later on can be confirmed with then confirmed with signs and symptoms, which are helps for diagnosis. If RBC having less than acetylcholine esterase levels of less than 25%, severe toxicity can be seen. These are RBC, these levels are more specific than blood levels, and these levels will confirm diagnosis, whereas the signs and symptoms adds to the diagnosis, which helps us to confirm the diagnosis, and exposure basis on and history taking can help even more. Coming to the grading of clinical severity, these can be divided into three: mild, moderate, and severe. If acetylcholine esterase levels are more than 40%, these comes to mild. Symptoms mostly seen on muscarinic activities, which includes nausea, vomiting, diarrhea, salivation, bronchoria, and bradycardia. And whereas in CNS, it is on dizziness and headache can be seen. Coming to moderate, is around 20 to 40%, including all the above symptoms. Meiosis and incontinence will be added. In nicotinic effect, the fasciculation seen on fine muscles, and in CNS, including headache and dizziness, ataxia and dysarthria can be seen. Coming to severe, less than 20%, in less than 20%, more in nicotinic effect, more, along with fine muscle fasciculations, diaphragm and respiratory muscles are also involved. and in CNS, along with headache, dizziness, ataxia, dysarthria, and coma and convulsions can also be seen. These are the investigations we need to send, which includes ABG, which shows day-ranged PaO2 and PaCO2 levels, venous blood for estimation of RBC, RBC acetylcholinesterase, and concentration of organophosphorus compounds. For biochemistry, which includes mostly electrolytes, glucose, amylase, lipase, and creatinine, and hematological examination should be done. A chest X-ray should be sent for finding any aspiration and pulmonary edema, and ECG has to be taken to rule out arrhythmias and heart block. This is approach to the management mainly for OP poisoning, which includes initial supportive care, prevention of absorption, enhancement of elimination, and delivery of antidote and treatment. In initial supportive care, as general poisoning, we need to take care of airway, breathing, and circulation. In OP poisoning, even in mild to moderate poisoning is also considered, intubation should be considered. Avoid the use of succinylcholine while inducing. Non-depolarizing NM blocking agents can be used, but higher doses may be required. Bradycardia and hypotension are commonly seen in OP poisoning. Adequate fluid volume should be used for resuscitation. Coming to prevention of absorption, for gastric decontamination to be done only after the initial instabilization, initial stabilization, and treated with atropine and an oxime. Gastric lavage, there is no proper randomized control trials to confirm benefit, considering it only if the patient arrives within 1 hour of ingestion of poison. Activated charcoal can be used, which is used to bind to OP poisoning compound in vitro, but there is no evidence to suggest benefit if patient arrives within 1 hour. Coming to enhancement of elimination, randomized control trial of multiple doses of activated charcoal failed to find a significance of either regimen or placebo. Roles of hemodialysis and hemofiltration are not yet clear. No randomized control study from China benefit of hemofiltration after poisoning with dichlorophos is seen, which has a poor solubility in fat. Therefore, should have a relatively small volume of distribution. Coming to antidote, muscarinic blocking agent should be used, which is atropine is most commonly used, and glycopyrrolate can also be used in some situations. Chlorine extras activators are used. Generally, we use pralidoxin, which is generally called as PAM, and benzodiazepines can also be used for agitations and convulsions. Coming to atropine, the main aim of early therapy is to reverse cholinergic features and to improve cardiac and respiratory functions as quickly as possible, and rapidly reversing bronchospasm and bronchoria. Coming to dosing, it has a loading dose of 1 to 3 mg IV bolus, and double the dose every 5 minutes. Excessive atropine can also cause atrophinization, which leads to drying of secretions and increased heart rate. And maintenance dose is hourly 10 to 20% of total dose needed to stabilize the patient. Glycopyrrolate can also be used, which does not cross blood-brain barrier and has lesser CNS side effects as like atropine and better control of secretions. Indicated either as an adjuvant to atropine for control of copious secretions, and when features of atropine toxicity like delirium are confused with CNS effects of poison. For initial control, atropine must be used as it has an advantage of CNS effects. This table shows the effects of atropine. and glycopyrrolate, including with CNS effects like CNS penetration, delirium, coma reversal, respiratory function improvement can also is good with atropine. And control of OP poisoning induced seizures can also be are better with atropine comparing to glycopyrrolate. Coming to pralidoxin, generally called as PAM. Pralidoxin binds to OP compounds and reactivates the phosphorylated acetylcholinesterase. Reactivation mostly at a skeletal muscle than at autonomic site, which reverses nicotinic symptoms. Coming to dosing, 30 mg per kg, which is a loading dose over a period of 10 to 20 minutes, followed by continuous infusion at the rate of 8 to 10 mg per kg per hour. These should be continued till clinical recovery or at least up to 7 days. For pralidoxin, there is a lot of controversies happening since long on a synergistic effect with atropine, respiratory failure reported with PAM use, especially with a high dosage. Studies showing the beneficial effect of PAM use in dispute regarding mainly of dose of poison, non-comparable groups, timing of start of therapy, etc. These are observations of a PAM, which includes higher dose of PAM is more beneficial that is decreased requirement of atropine in first 24 hours, decreased duration of mechanical ventilation, decreased mortality, and it has minimal side effects. Coming to intermediate syndrome, even after treatment, some amount of OP poisoning can be deposited in adipose tissue or fatty tissue. Later on releases into the system, mainly seen in the condition of muscular weakness and paralysis that occurs 1 to 4 days after the resolution of acute cholinergic toxidrome due to organophosphate exposure. The clinical features mainly includes facial or neck proximal muscle weaknesses. Patient can't able to hold their neck, and includes cranial nerve palsies, respiratory muscle weakness, depressed tendo reflexes. Coming to management, there is no specific treatment is indicated, and patient needs a close supportive care and management. Generally, it is self-limiting. Thank you, sir.
Hello,
Sir,
Shankar, అప్పుడే అయిపోయిందా? Thanks, Allah. What is the treatment you have mentioned? I didn't follow that. Sorry for this. ఒకసారి వెనక్కి వెళ్ళవా? Okay. Okay, Shankar. Very fast and rapid roundup. What is the dose of PAM? Start depends on the cholinesterase levels or depends on the patient symptoms.
The recommended dosage is 30 mg per kg, sir, which is a loading dose over a period of 10 to 20 minutes, sir. That need. Hello.
Sir, question of sir complete the Venu Shankar.
Sir.
క్వశ్చన్ ACHA లెవెల్స్ మీద డిపెండ్ అయ్యి చేస్తారా, సివియారిటీని చూస్ చేస్తారా, లేదా టైం పెట్టి చేస్తారా అనేది సార్ క్వశ్చన్.
Mostly depend on clinical signs and levels only, sir.
Hello,
Sir.
శ్రీనివాస్ ఏంటి?
తను ఏదో చెప్తున్నాడు సార్. అదే మీ క్వశ్చన్ సరిగ్గా
చెప్పట్లేదు మన
వినమని
క్వశ్చన్.
చెప్పాను.
అంటే will dose change depends on the severity or it is a fixed dose?
Infusion can be changed, sir. 8 to 10 mg పెట్టుకోవచ్చు.
పెద్దగా మాట్లాడు.
సార్, హలో సార్.
Talk little bit loud.
Loading dose is there, sir. Loading dose will be used, sir. Depends upon clinical effect. These infusions can be changed, sir.
So how long you will
ఇంకెవరైనా
continue the
రెసిడెంట్
dose?
బెటర్?
ఏంటి?
అదే ఇంకెవరైనా రెసిడెంట్స్ ఉన్నారు కదా, ఇంకెవరైనా బెటర్ ఆన్సర్ ఇస్తారేమో.
If anybody can give the answer.
చరిష్మా, డాక్టర్ తృప్తి, ఎవరైనా రెసిడెంట్స్ ఆన్సర్ చేయాలంటే ఆన్సర్ చేయండి.
Sir, good morning, sir.
చెప్పండి సార్.
Sir, in OP poisoning, we can also give 10 to 20 mg per ml over 15 to 20 minutes. And usually the dose is repeated after 12 hours and generally given for 5 days, sir, in our setup.
Patient comes after 24 hours, will you start the Palidoxime or it is not useful?
For every patient, we put Pralidoxime, sir.
How do you identify the patient is having some patient comes with poisoning, some pesticide poisoning. You don't know whether
Yes.
it is organophosphorus or not, but how do you identify organophosphorus poisoning?
Yes, the smell is very typical, sir. When they come, there is one kind of odor. Usually the history is suggested. Then there is an odor also coming from the patient. And we send for test. We send the blood for testing also, sir.
But will you wait till you get the test?
No, sir, we don't, sir. We don't. The toxidrome of dumbbells, which he said, which is diarrhea, meiosis, bradycardia, urination, sludge.
What
all
are the
that we-
clinical signs you will see for looking for organophosphorus poisoning?
clinical signs, sir?
Yes.
Yes, sir. So there is like bradycardia, meiosis, then bronchoconstriction will be there, lacrimation, urination, vomiting. Also fasciculations will be there, sir. If the dose is very high, then the patient may come in comatose state also with seizures or apnea, bradypnea like that.
Okay. Right. Any other audience? Any questions?
Sir.
Srinivas, you carry on.
Nice,
Anna,
nice presentation. I actually missed the talk, David. At what time you will send this serum cholinesterase levels? Before, at the time of admission, or you wanted to wait for some more time?
After admission, sir.
Huh?
We can send after admission only, sir.
admission before admission you don't send kada inti daggara.
After
He is asking
admission,
at what time? Immediately or after some time, after 6 hours, after 12 hours or 24 hours?
Immediately we can send, sir.
And if you send immediately, and means usually after ingestion of the poisoning, we have to wait for 6 hours. Okay.
Yes, sir.
If
Yes,
we
sir.
send before that, it comes normal. Okay. Huh?
Yes,
So
yes, sir.
after the 6 hours only, you have to send. Huh?
Yes, sir.
Do you monitor this one regularly?
Yes, sir.
Monitor serum cholesterol. Any significance is there regarding the, if suppose it is initially low, it's slowly increasing. Any significance is there?
Uh,
అయిపోయింది సార్.
Guideline says no need to repeat the serum cholesterol levels. Okay.
No, serum cholesterol levels does not reflect or does not correlate, అంతే కదా.
అంతే సార్, అంతే సార్.
కానీ I also do it. I also do it normally. Better to do once because to understand.
సార్ డయాగ్నోసిస్ కి సార్ అది డౌట్ ఉంటుంది
సార్ మీరు చేస్తారు, కుచల గారు చేస్తారు సార్. యంగర్ జనరేషన్ గైడ్ లైన్స్ ప్రకారం నో నీడ్ అంటాడు సార్. దే విల్ ఆస్క్ ఇన్ ద ఎగ్జామ్.
చేయొద్దని చెప్తున్నాను, చేయమని కాదు సార్ నేను చెప్పేది. చేయమని చేయొద్దని కాదు. నాట్ క్లినికల్ ఇస్ మోర్ ఇంపార్టెంట్ అలాంగ్ విత్ ద కొలెస్ట్రాల్ ఎంజైమ్ లెవెల్స్.
ఓకే సార్, ఓకే.
But did anybody hear the organophosphorus topic from Pradeep Rangappa sir recently?
No sir, David garu, any point?
No,
So
sir.
he said it won't reflect the duration of recovery and
Okay.
normalization of the acetylcholinesterase, but it also indicates the severity of
Yes.
the poisoning and the recovery, that time of recovery of the patient, not the recovery of the cholinesterase. If anybody, Shankar, did you hear that? I told Rani madam.
సార్
Madam,
సార్ సార్ డేవిడ్ సార్
ah,
అగ్రీ విత్ దట్. అంటే ఇట్ టెల్స్ us the severity of the poisoning, but
yes.
that has to be done at once. Daily monitoring is
Also,
ongoing.
recovery also. That's what I'm asking. Did
అంటే
anybody hear
సివియారిటీ అంటే
that?
ఇంకా తెలిసిపోతుంది కదా సార్. ఇట్ ఈస్ వెరీ లో.
డేవిడ్, నేను ఏం ఆలోచిస్తున్నానంటే నార్మల్ గా ఐ డోంట్ హ్యావ్ మచ్ ఎక్స్పీరియన్స్ విచ్ లెస్ ఎక్స్పీరియన్స్. ఇఫ్ ద లెవెల్స్ ఆర్ లో, ఐ ఎక్స్పెక్ట్ ఇంటర్మీడియట్ సిండ్రోమ్. ఇఫ్ ద లెవెల్స్ ఆర్ మోర్, ఐ విల్ నాట్ ఎక్స్పెక్ట్ ఎర్లీ ఎక్స్ట్యూబేషన్ ఇస్ ఓకే అనుకుంటాను. అది నేను చెప్పేది.
That is there.
సార్ అది సార్ మోహన్ సార్, అంటే ఇంటర్మీడియట్ సిండ్రోమ్ దగ్గర ఎలా అంటే వన్స్ యువర్ లెవెల్ స్టార్ట్స్ ఇంక్రీజింగ్ అండ్ స్టార్ట్స్ డిక్రీజింగ్, అప్పుడు అంటే కొన్ని స్టడీస్ అలా సస్పెక్ట్ చేశాయి ఇంటర్మీడియట్ సిండ్రోమ్. వన్స్ ఇట్ కమ్స్ టు నియర్ నార్మల్ అండ్ దెన్ స్టార్ట్ డ్రాపింగ్ అగైన్, అప్పుడు దే సే దట్ దేర్ ఈస్ ఎ ఛాన్స్ ఆఫ్ ఇంటర్మీడియట్ సిండ్రోమ్ ఇన్ ఎడిషన్ టు ద క్లినికల్ సైన్స్ అండ్ సిమ్టమ్స్. అలా తీసుకున్నారు. బట్ ఇట్ ఈస్ నోవేర్ దెర్ ఈస్ ఎ రికమెండేషన్ that you have to send ACH levels to get to know it is an intermediate syndrome or not.
But if patient develops intermediate syndrome, he will repeat the acetylcholinesterase, whether it is dropping or same or increased. Mostly it will drop.
Yes.
సార్ ఇంటర్మీడియట్ సిండ్రోమ్ అప్పుడు అవసరం లేదు సార్. ఓన్లీ థింగ్ ఈజ్ ద ఇంటర్మీడియట్ సిండ్రోమ్ క్యారెక్టరిస్టిక్ ఏంటంటే లార్జ్ అమౌంట్ ఆఫ్ పాయిజన్, then delay in the treatment, basically delay into the coming to the hospital. So and not appropriate treatment.
But at the same time, large amount of poisoning will cause a decrease in the cholesterol levels, no? Very,
yes sir, yes sir. అది అందుకనే ఒకసారి చేస్తే it will tell us the severity.
yes,
severity ని బట్టి మనం సస్పెక్ట్
పాయిజనింగ్ అబ్జార్బ్ అయిందని ఎంత పాయిజనింగ్ తీసుకోవడం తెలుస్తుందా?
But still, recently, this week, Dr. Rangappa sir put the YouTube in organophosphorus poisoning. I sent this Rani madam yesterday. Please go through that latest guidelines also.
మోటార్లో పెట్టండి సార్.
పెడతాను సార్ అలాగే. సో
సార్ మెయిన్ ప్రాబ్లం ఎక్కడ వస్తుంది అంటే ఇంటర్మీడియట్ సిండ్రోమ్ దగ్గర ప్రాబబ్లీ మీరు చేయాల్సి ఎందుకు వస్తుంది అంటే ఇట్ ఈస్ బికాస్ ఆఫ్ ఫ్యామ్. ఫ్యామ్ కూడా దెర్ ఇస్ అ ఛాన్స్ ఆఫ్ మస్కులర్ వీక్నెస్. సో ఆ రెండిటి కన్ఫ్యూజన్ ప్రాబబ్లీ ఆ డిఫరెన్షియేషన్ చేయడానికి మేబీ ఇట్ ఈస్ ఆఫ్ యూస్. ఆ ఛాన్స్ అయితే రావచ్చు. అలాంటి దగ్గర మీరు యూజ్ చేయొచ్చు. ఫ్యామ్ యూ కెన్ హ్యావ్ ద సిమిలర్ సిమ్టమ్స్.
ఓకే, What is the
Muscular
maximum
weakness.
dose of PAM we will give per day? Shankar? Patient is very severe organophosphorus and respiratory arrest in coma.
ఇప్పుడు కీర్తి పవార్ చేసింది కదా స్టడీ,
అదే.
లాన్సెట్ లో పబ్లిష్ అయింది, ఆ బుక్ కూడా ఇచ్చింది.
ఆ book
ఒక్కసారి
is
హాఫ్
there.
ఇస్తే సరే మళ్ళీ ఫుల్ డోస్ ఇవ్వాలని చెప్పేసి ఆ బుక్ కూడా ఇక్కడ ఉంది.
అదే ఉంది, నా దగ్గర ఉంది. That's what I'm asking, that what is the maximum dose of PAM in a severe organophosphorus poisoning with severe symptoms like patient in respiratory arrest and coma? What is the maximum dose per day? As the WHO guidelines, you said 30 mg per kg bolus followed by 8 to 10 mg per kg per hour infusion. Maybe it is 3 days. Some people give 5 days. Some people will give 1 week. It depends upon the patient recovery. But what is the maximum dose allowed?
Sir, allowed maximum dose తెలియదు కానీ we used to give approximately 15 grams of per day.
Okay,
for
but
3 days.
మోహన్ సార్ చెప్పారు కదండి ఇప్పుడు. There is
సార్ అంటే 30 mg WHO గైడ్లైన్స్ సార్, WHO గైడ్లైన్స్ ప్రకారం 30 mg అనుకుంటాను సార్. ఫాలోడ్ బై సమ్ 8 mg per kg బాడీ వెయిట్
అవును.
48 to 72 hours.
కాకుండా one lady, she did మోహన్ సార్ చెప్పాలి క్లాస్మేట్, she did
Okay.
one study on in India and she
Okay.
published one book with all other international organization support. And what she said in the book is there with me. In that she mentioned, if poisoning is very severe, patient is not recovering on ventilator, you have to give 1 gram per hour infusion
Okay.
as long as patient is on ventilator.
Sir, sir, ఇప్పుడు నాట్ రికవరింగ్ and how you will know, sir?
Patient
Because you know,
అదే
అంటే
not
severity
coming
బట్టి.
up ventilator, respiratory arrest
అంటే
patient in
సార్ అది మనకు తెలిసేది 2-3 రోజుల తర్వాత తెలుస్తుంది వస్తుందా లేదా పేషెంట్.
అదే కంటిన్యూ అంటున్నా ఆవిడ, అది నేను అంటున్నా.
అంటే అంటే ఎవిడెన్స్ ఇండియన్ ఓల్డ్ స్టడీస్ కూడా ఉన్నాయి సార్. దే హావ్ గివెన్ వాట్ రికమెండెడ్ బై WHO కాకుండా డబుల్ ద డోసెస్ ఇచ్చారు. ఇచ్చినప్పుడు రికవరీ వాస్ గుడ్. సో దట్ ఈస్ ఫ్రమ్ ముంబై. దెన్ లాట్ ఆఫ్ స్టడీస్ ఫ్రమ్ శ్రీలంక, చైనా అండ్ ఇండియాలో ఎవిడెన్స్ లేకపోయినా కానీ లాట్ ఆఫ్ దేర్ వాజ్ డిక్రీజ్ ఇన్ ద అంటే పవర్, అంటే మస్కులర్ వీక్నెస్ పెరిగింది. సో అండ్ పేషెంట్స్ ఆర్ నాట్ కమింగ్ ఆఫ్ ద వెంటిలేటర్ with PAM because of the PAM. So there was a lot of controversy role for PAM. Patients will not, the delay in the mortality pergaledu gani there was a delay in the coming out of ventilator. It means length of stay on ventilator is high. So that's the reason why some of the studies doesn't recommend the PAM to be used for all the patients. And even in spite of severity also, the increasing the PAM use increases the muscle weakness. ఇది ఒకటి. సో బట్ WHO still recommends PAM
for intermediate syndrome also. If patient after 1 week improved and shifted to ward and again patient developed respiratory weakness and respiratory almost failure, go on intubation and ventilation. Again, can you use the PAM? Restart the PAM, Shankar?
No sir.
No?
Sorry Shankar.
What Srinivas? M Srinivas?
No, sir. No.
No. Jakina?
No sir. No role.
No role of PAM, restarting PAM for intermediate syndrome, right?
Yes sir.
But this book says you have to start PAM again.
మళ్ళీ ఫుల్ డోస్ ఇవ్వాలంటారు.
Full dose. Yes, again we have to start the full dose and continue.
Sir, full dose initial గానే కాంట్రవర్షియల్ ఉంది సార్. PAM ఇంటర్మీడియట్ సిండ్రోమ్ కాదు సార్.
జేవి పేటర్ అదే కదా చేసింది.
ప్రాబ్లం ఏంటంటే రిసెప్టరే మారిపోతుంది కదా సార్. ఇప్పుడు నికోటిన్ కి యూ కాంట్ రివర్స్ ఎట్ ఆల్. అది ఇది NM, NN రెండు ఉంటాయి కదా, అందులో ఇనీషియల్ గా వచ్చేది NM ఎఫెక్ట్ అవుద్ది, తర్వాత ఇంటర్మీడియట్ లో ఎఫెక్ట్ అయ్యేది NN ఎఫెక్ట్ అవుద్ది. అది దేంతోనే రెస్పాండ్ అవ్వదు. సో వాట్ పారాడాక్సిమ్ రివర్సెస్ ఈజ్ NM.
But still some consultants are restarting. whether the effect, whatever it is, that there may not be any randomized control studies to finalize this, but some concerns are starting. Recently, we had one case. It shifted from Vijayanagaram Medicover. Patient on ventilator since 15 days, unable to wean off after 20 days also. Trachectomized after 10 days. 21st day shifted Pinnacle. Patient is unable to wean off. So, and PCOT is also going up. Even she is not tolerating pressure support. PCO2 is around 90, 100 like that. Patient is very weak and drowsy, arousable. So we received that patient and we restarted the PAM here and we put on ventilator, sedated and continued ventilation for 2 days, 48 hours. Later we stopped the sedation and we started weaning off, but once you put pressure support, she is going into respiratory failure and backup continuously. So again, another 2 days we continued on control mode with sedation. Again, we weaned off sedation and put on pressure support. Like that, 2-3 episodes are there. Third attempt, she is able to. Meanwhile, we excluded all the nutritional deficiencies and all the electrolytes, abnormalities, and vitamin support and TPN. We have started. We have started all severe hypoalbuminic. We started albumin and phosphorus also is low. We have started a POTFOS, that potassium and phosphorus infusion. So vitamin deficiencies, all this corrected. Nutritionally, she is improved with good nutritional support, and also she developed 105 temperature and E. coli in the blood, both blood cultures and urine culture, everything is. And one time she developed seizures and become unresponsive. 105 temperature with 170, 180 heart rate. So again, we took the cultures and started meropenem and tigecycline also, Targocid, and even antifungals also I started because it is growing heavy growth of this Candida. But young patient, 20 years and married 3 months before, and she is pregnant also. Pregnancy, this also terminated by gynecologist. So she recovered from the sepsis after 3-4 days and become again conscious. And after that, she developed some psychiatric illness, shouting and pulling out everything. Shown to psychiatrist, started some antipsychotic drugs. So finally, today is, 1 week back, 5 days back, she shifted to ward with, after closing the TPs, tracheostomy tube. Yesterday, 2 days back, she came for removal of the tracheostomy tube. Now she is fine. She is about to discharge. That is means almost 40 days after the consumption of the organophosphorus. 20 days in Vijayanagaram, 20 days in our hospital. That is our experience in organophosphorus.
సార్ అంటే ఇప్పుడు కన్ఫౌండింగ్ అయిపోతుందేమో కదా 40 days అన్నప్పటికీ ప్రాబబ్లీ మీ ఇంటర్మీడియట్ సిండ్రోమ్ కొద్దిగా రికవరీకి వచ్చేసి ఉండొచ్చు. ఐదర్ బి
అదే
ప్యామ్ వల్ల అయ్యి ఉండొచ్చు, లేకపోతే ప్యామ్ వల్ల ఇవ్వకపోయినా అదే కన్ఫౌండింగ్ అవుతుంది.
We don't know exactly. It is a intermediate syndrome, definitely with all nutritional sepsis. Everything is compounding factors to have this problem. What is the role of this hemoperfusion, hemodialysis in organophosphorus poisoning? Shankar?
Sorry, hemodilution, there is no role can be seen, sir. But in hemoperfusion only for in some situations it's useful. It might be useful, sir. But
what is the time limit to start the hemoperfusion when patient gets benefits? Are there any studies to prove that hemoperfusion will improve the organophosphorus, reduce the severity? మీకుంది కదా, you did some, Srinivas? You did
Sir.
some case in care, no?
లేదు సార్ ఇక్కడ చేయలేదా
Mohan Raj చేసినట్టు.
చేద్దాం అనుకున్నాం కానీ చేయలేదు. అదే మీ ఇక్కడ ఆ డాక్టర్ ఎవరో వచ్చారు కదా ఒక అమ్మాయిని
అవునవును.
P+ సంథింగ్ దానికే అనుకున్నాం. యాక్చువల్ గా హైదరాబాద్ డెక్కన్ లోనే దేర్ వర్ సమ్ స్టడీస్ దట్ వర్ గోయింగ్ ఆన్ ప్లాస్మోఫెరెసిస్ ఫర్ దిస్ ఇక్కడ ఇంటర్మీడియట్ సిండ్రోమ్ కి. సో దానికి చేశారంట. బట్ యాజ్ సచ్ నో అంటే అదే ఇంకా ఎక్స్పీరియన్స్ ఇక్కడైతే చేయలేదు.
Shankar,
Sir, madam.
what is atropinization means? Patient is atropinized ante enti?
Overutilization of atropine, which causes a patient to
Like overutilization, Shankar. What is madam is asking, what is
Atropinization
atropinization?
target.
There is a mnemonic.
Okay. I think better to ask some basic questions to the students also. Shankar, maybe this is the homework for you, madam, what she asked. Huh?
Yes, sir.
Shankar?
Sir.
OP poisoning case present చేసావంటే atropinization అంటే ఏంటి అని అడుగుతారు శంకర్. Once you start treating the patient 4 days ki your treatment is going on, third, fourth day patient is developing high temperature. Enti your DDs enti? Why the patient is developing temperature? What do you do that time? Em cheyali?
Madam, I think we have less time, madam. We have to give the homework for this kind of questions. So, apart from that, Shankar,
Sir.
Apart from atropine, do you use any other drug?
Sir, glycopyrrolate can be used, sir.
In which conditions you use instead of atropine? What is the advantages, disadvantages also you should know.
Glycopyrrolate does not pass blood-brain barrier, sir.
Okay.
It has lesser CNS side effects.
Okay.
And has better control of secretions, sir.
What is the disadvantage? Then
Okay.
if there is no disadvantage, everybody will give glycopyrrolate, no? To avoid this psychosis, atropine psychosis, all.
Sir, it has no role in CNS manifestation. It has no role in CNS manifestation, sir. Like in.
అందుకనే లేనప్పుడు everybody will give glycopyrrolate instead of atropine to avoid this atropine. Madam చెప్పారు atropinization, atropine psychosis, atropine related complications like severe tachycardia, psychosis, hyperthermia.
నీ పేషెంట్ హార్ట్ రేట్ 50-60 కంటే పెరగట్లేదు. విచ్ వన్ విల్ యూ చూస్? ద పేషెంట్ హ్యాస్ లాట్ ఆఫ్ సిక్రిషన్స్ చాలా ఉంది. హార్ట్ రేట్ పెరగట్లేదు. విచ్ వన్ డు యూ ప్రిఫర్?
Atropine, madam.
What is the target heart rate? Is it target people reaction or it is target heart rate you will see with atropine?
Or what is the main target you want to achieve? చెప్పావు కదా ఇందాక.
More than 80 beats per minute, madam.
Huh? More than 80, yeah.
More than 80, sir.
More than 80 or 100? More than 100.
Shankar, apart from the paradoxum, any other drug can we give? Any other components you people should know, should read in detail about the pharmacology also. One is India, right and left, it is available. Any other drug is available?
Trimethoxam is there, sir.
Huh? The Paradoxum also, there are two components, sir. Actually, I read long back. Actually, right now, what we are having, that compound have a more and more side effects. Other molecules, which is a chloride based, I think. That is less. Another thing is when you are the patient OP poison is coming, is there any difference between the component to component? Suppose monocotophos, dichlorophos, pyrimethophos, pyrichlorophos. So which compound, is there any significance? Because few
Yeah, which is
compounds.
dangerous. There are two types. Two types of
Sir,
organophosphorus, which
sir,
is dangerous.
let the student should note, and he has to
Yes.
make it. So, which some compounds actually we can predict the patient may develop into intermediate syndrome. And with some compounds, chance of prolonged recovery and neuromuscular weakness.
Yes, sir.
When you are, means preparing, you have to read each and everything also. These are all things.
Shankar, what type of organophosphorus compounds available? How many types? And as Mohan sir asked, which one likely to cause intermediate syndrome? కొన్ని పేర్లు చెప్పు నువ్వు పెస్టిసైడ్స్.
Melatonin, diazinon, parathion,
ఓకే, ఇంకా
trichlorophon is also there.
ట్రైక్లోరోఫాస్, మోనోక్రోటోఫాస్. సో నువ్వే చెప్పే ఇప్పుడు. ఒకటి థయోన్ గ్రూప్, ఒకటి క్రోటోఫాస్ గ్రూప్స్. ఓకే,
Yes, sir.
phos means organophosphorus compound. So what is the chemical structure of the organophosphorus and why it is called organophosphorus? Phosphorus అని అన్నారు కదా.
Yes, sir.
What is the chemical structure? అంటే అది ప్రజెంట్ చేసినప్పుడు నువ్వు అసలు ఆ పాస్ అన్న పేరు ఎందుకు వచ్చిందో, థియోన్ అన్న పేరు ఎందుకు వచ్చిందో డిపెండ్స్ ఆన్ ది కెమికల్. దేర్ ఆర్ టూ టైప్స్. యూ షుడ్ నో, because they may ask, if they go into deep, why the phos, why the thion group, what is the both significance of both groups, which is more dangerous. Okay,
Yes, sir.
just if you heard monocrotophos, what is organochloride? Organophosphorus లాగానే organochloride అని ఉంటుంది కదా. And what is organocarbamate? So what is the difference of these three poisonings, and what is the major treatment option for these three? For every case, will you start PAM and atropine?
No, sir.
These are three are more commonly available in India, along with paraquat. Okay. But organocarbamate, organochloride, and organophosphorus. And in organophosphorus, you have to again differentiate the thion group and phosphate groups. And because treatments will change for each type of poisoning. ఇది కూడా మీకు తెలియాలి ఒక పాయిజనింగ్ కేసు ప్రజెంట్ చేస్తున్నప్పుడు. అర్థమైందా?
Okay, sir. Yes, sir.
ఏంటి సార్ మళ్ళీ చెప్పండి.
There are three types of commonest organ compound poisoning, sir. Organocarbamate, organochloride, and organophosphorus. In organophosphorus, the two types, one is thion group and phosphate groups. Thion groups are more dangerous, like parathion, malathion, these trade names. And monocrotophos, trichlorophos, the phosphate groups, they are not that much dangerous. And thion groups are likely to develop intermediate syndrome. And phosphate groups are, they can cause, but when compared to this, it is less severe. And treatment will change for chloride, organochloride, and organocarbamate and organophosphorus. These three differentiates, and they will ask the chemical structure of this compound. Why organochloride, why organocarbamate, why organophosphate. They will ask the chemical structure. Why this name is changed for each. Because treatment will also change. What is aging effect, Shankar? What is the meaning of aging? And which part of the neuromuscular junction this organophosphorus compound will attach and causing irreversible complex? Shankar,
Sir.
so which part of the neuromuscular junction this will go and attach and causing the irreversible complex? And what is the mechanism of the atropine? How it acts? And what is the mechanism of the PAM and how it acts? PAM ఏం చేస్తుంది?
Reactivates the phosphorylated acetylcholinesterase, sir.
ఇంకా ఈ organophosphorus compound where it will go and attach? If it reactivates, the patient immediately will recover. No, why it takes long time? What is the role of atropine? Why you are giving atropine?
Mainly to reverse cholinergic features, sir.
Cholinergic?
Features and improve cardiac, like improve
అంతేనా?
cardiac
అదా దాని ఎఫెక్ట్?
respiratory functions.
That means it is only symptomatic use. అంటే బ్రాడీ వస్తే ట్యాకీ చేయడానికి అంతేనా? ది పీపుల్ మియాసిస్ ని మిడ్రియాసిస్ కన్వర్ట్
శంకర్
చేయడం.
ఓపీ పాయిజనింగ్ కేసు వచ్చిందంటే చాలా అడుగుతారు ఇన్ డీటెయిల్ ఆల్ దిస్ యూ హావ్ టు నో లిటిల్ మోర్ ఇన్ డీటెయిల్. ఓకే, ఈ అడిగిన క్వశ్చన్స్ అన్నిటికీ ఆన్సర్స్ చదివి ఈ గ్రూప్ లోనే పెట్టు.
కంపల్సరీగా అడుగుతారు. దిస్ ఇస్ మ్యాండటరీ. వై ఇట్ ఈస్ కాల్డ్ యాంటీడోట్. యాంటీడోట్ అంటే ఏంటి అసలు? వాట్ ఈస్ యాంటీడోట్? వాట్ ఈస్ టాక్సిడ్రోమ్స్?
Antidote is reverses the toxicity of poison.
ఏంటి? So what type of MLC? It is MLC, no? It is suicide. Okay, majority people will take alcohol with poisonings, right?
Yes, sir.
So yeah, how will you differentiate the patients with having other mixing poisonings and consuming other alcohol or something else with that? అప్పుడు ఎలా MLC follow? What are the precautions you will take? Will you send the samples, urine sample and blood sample and this Ryle's tube and gastric samples to forensic department?
Yes, sir.
What precautions you will take?
Like proper sanitization should be taken, and
Sanitization.
staff will use proper PPE kits.
So how will you manage organophosphorus case? If patient comes with a 20 years young man, he brought to here in unconscious state, gasping, profuse sweating, and heart rate is 40. How will you manage how will you manage this case? Approach.
Initially, we look for airway, breathing, and circulation, sir.
Shankar, what do you do for yourself? Start from there. You can smell horrible smell, and he's all vomiting and sweating, all body fluids on him. So, what do you have to do first? You saw the patient coming in quickly. What do you want to do for yourself?
Unable to record the SpO2, pulse is feeble. The patient is crashing. What you will do? You are in ER.
We airway breathing and circulation should be taken care, sir. And before that, we need some personal protective equipment, includes mainly gloves and all that.
నువ్వు కా పేషెంట్ గా
Manaki, sir.
నువ్వు వెళ్ళి పీపీ కిట్ వేసుకొని వచ్చేసరికి పోతాడు, ఇక్కడ అరెస్ట్ అయిపోతాడు. ఇమ్మీడియట్లీ వాట్ యూ విల్ డూ? టెలింగ్ ఏబిసి, బట్ యూ టెల్ వాట్ యు ఆర్ ప్రాక్టికల్లీ ఆర్ డూయింగ్ ఆన్ బెడ్ సైడ్. క్లీనింగ్ పేషెంట్ అరెస్ట్ అవుతుంటే క్లీన్ చేస్తావా? ఏమా, ఎనీ అదర్ స్టూడెంట్స్? హలో,
How many students in this right now?
Good morning, sir.
గుడ్ మార్నింగ్. ఎవరు?
Sir, I'm Dr. Santosh, sir, Care Hospital Anesthesia.
స్టూడెంటా మీరు?
Sir, DNB student.
Resident, sir.
ఓకే, సరే చెప్పండి, ఏం చేయాలి ఇమ్మీడియట్ గా?
Sir, first we'll wear gloves, sir. Tarvata patient clothing has to be removed, sir, because the organophosphate components can be
Sir,
absorbed through
లిజన్,
skin.
హలో, నేను చెప్పిన సినారియో అన్నారా మీరు?
Yes, sir.
మీరు గ్లవ్ వేసుకుంటారు, ఓకే. పేషెంట్ కి బట్టలు కూడా తీసేసి ఆ బట్టలు ఉతికి వాడిని సబ్బుతో కడిగి ఇవన్నీ కాదండి. పేషెంట్ ఈస్ డైయింగ్, బ్రాడికార్డియా, పల్స్ ఫీబుల్, గ్యాస్పింగ్ స్టేట్ అండ్ హీ హాజ్ వామిటెడ్ ఆల్రెడీ. మొత్తం బట్టలన్నీ ఇదైపోయింది,
Will intubate, sir.
లైఫ్ ఎమర్జెన్సీ, లైఫ్ సేవింగ్ మెకానిజమ్స్ చేయాలి కదా. ఫస్ట్ ఏబిసి ఏం చేస్తున్నా, ఏం చేయాలి అన్న చెప్పాలి. ఏబిసి కాదు అక్కడ నుండి.
First we will intubate the patient, sir, so that we can secure the airway.
Okay.
Then we'll start atropine, sir, because to increase the heart rate and then we will remove the clothing if possible, sir, because that can be absorbed through skin also. And these organophosphate compounds binds to the acetylcholinesterase enzyme, cerebral factor. So when we give pyridoxine, the phosphate group reacts with the oxime group of the pyridoxine.
ఎంత ట్రోపిన్ ఇస్తారు మీరు? ఇవన్నీ మెకానిజం ఇప్పుడు కాదు, ఎప్పుడు ఇస్తారు? ఎంత ఇస్తారు ఎట్రోపిన్? 1 ampoule?
Less, sir.
4 ampoule contains how much atropine?
1 mg, sir. 1 mg, sir.
0.6 mg, sir. 0.6 mg.
0.6 mg.
But vial, 50 ml vial contains how much atropine?
30 mg, sir.
No, each ml contains.
Each ml contains.
Vial లో 1 ml 1 mg అంటారు సంతోష్.
Vial లో 1 ml contains 1 mg.
Okay, sir.
So patient is in brady, how much bolus dose of atropine will give? What is called full atropinization?
Complete drainage of
No, ఎంత డోస్ ఇస్తే atropinization అంటారు? 1 ampoule?
దానికంటే David
3 mg per 3 mg, sir. 3 mg.
Vagolite, that's called vagolytic
Yeah,
dose.
vagolytic dose. Yeah.
Atropinization starts with 1.8 to 3 mg fast bolus 3 to 5 millimeter over a period of within 3 minutes system, sir.
So that is vagolytic dose.
Sir.
Then okay. So the management, one patient in shock, again same intubate చేసావు, తర్వాత ఎట్రోపిన్ ఇచ్చావు, ప్యామ్ ఇచ్చావు, నెక్స్ట్ ప్రాక్టికల్ గా ఏం చేస్తారు చెప్పండి బాబు. మీరు ఐసీలో వస్తా ఉంటే బోల్ కేసు
సార్ అప్పటికి ఇంకా అవ్వకపోతే లావేజ్ చేస్తాం సార్. రైల్స్ టు బేసి గ్యాస్ట్రిక్ లావేజ్ చేస్తాం సార్.
3 mg తో ఆపేస్తావా atropine?
శంకర్ ఎంతసేపట్లో అయితే గ్యాస్ట్రిక్ లావేజ్ చేయొచ్చు, అండ్ వాట్ ఆర్ ద కండిషన్స్ గ్యాస్ట్రిక్ లావేజ్ ఇస్ కాంట్రా ఇండికేటెడ్?
Before 1 hour కనుక పేషెంట్ ప్రెసెంట్ అయితే we can do gastric lavage, madam. And if patient is continuously having this MECs also, we can gastric emptying has to be done, ma'am.
ఏ కండిషన్స్ లో కాంట్రా ఇండికేటెడ్?
Some
corrosive poisonings లో
corrosive poisoning or acid based.
That is okay, but the patient came in drowsy state and okay,
సార్ చెప్పిన సినారియోలో ఇవ్వగలమా ఇవ్వకూడదా అనేది క్వశ్చన్.
డ్రౌజీగా అన్కాన్షియస్ ఉంటే ఏమవుతుంది?
Aspiration chances ఉన్నాయి, ma'am. So better to go for gastric emptying, ma'am.
Oh, this patient is already intubated. You protected the airway. Okay?
Yes, sir.
Now you can give gastric lavage to prevent aspiration. This is organophosphorus case, no?
Yes, sir.
How much charcoal you give? Activated charcoal, Shankar? What is the dose of activated charcoal?
1 mg.
చేసావా నువ్వు దీంట్లో?
1 mg per kg per
1 mg, yeah.
50 grams, sir. If the patient weight is more than 50 grams balls, single dose.
Activated charcoal.
Single dose of 1 to 2 grams per kg body weight, sir.
What it will do? What is the mechanism action of
It's
charcoal?
a non-reactive powder. It's non-absorbable. It has no intrinsic toxicity by itself. So it will cause the absorption of the poison. It's more effective for gastric decontamination, sir. It's the preferred method for decontamination when administered early, especially, and the non-toxic injections are. It's not indicated in non-toxic injections, but it is useful when it is administered early and in the dose of 10:1 ratio of toxin.
Okay. So any questions further, Srinivas, madam? Mohan Rao.
డేవిడ్ సూపర్ వాస్మోల్ ఏ పాయిజన్ కింద వస్తుంది?
ఏమో మేడం, గుర్తులేదు. బట్ ఆర్గనో కాంపౌండ్ కాదనుకుంటుంది. కరోజివ్ మేబీ, ఐ డోంట్ రిమెంబర్ దట్.
So in that poison, we used filters, hemofiltration.
Okay.
వాళ్ళల్లో యూస్ఫుల్, వాళ్ళల్లో వెరీ ఎర్లీ ఇంట్యుబేషన్, బికాస్ ఎడిమా వచ్చేసి దే లూజ్ ద ఎయిర్వే కదా.
అవును.
Shankar, what are all the drugs, dialyzable drugs? If you get a poison case, definitely they ask this. It may not be related to OP, but when you get poison case, you need to know few things. Dialyzable drugs?
Mostly barbiturates and salicylates. Lithium.
Good. అవన్నీ డైలైజబుల్, నాన్ డైలైజబుల్ చూసుకో. Poisoning వచ్చిందంటే they ask almost all poisonings.
Okay, Shankar, David, thank
Shankar,
you.
yeah. Shankar, nice presentation. But still, you need more preparation and of the all poisonings. Okay.
Okay, sir. Thank you, sir.
Even chemical structure also you should know.
Thank you, Shankar and David.
Thank you, sir. Thank you, Rani Madam and Srinivas for moderation. Thank you all the consultants for your
Thank
effort. Thank you.
you. Thank you.